Hello guys, this is Adit. Welcome to my channel Movement Science, where I simplify biomechanics and lot of ortho topics with Joe. So if you are new to this channel, consider subscribing. Also check me out on Instagram, where I post pictures of my notes and also put out daily MCQs with which you can brush up your biomechanics. The reference time for all the topics that I'm going to cover will be mentioned down in the description. So check that out and let's get started. In this video, we are going to talk about the hip joint flexors. The last video was about the introduction to all the hip joint muscles. So this video will be focused towards flexors of the hip joint. So let's start with the topic. The first muscle that we are going to look at is the iliopsoas, which can be divided into Illiacus and psoas major. The function of Illiacus is anterior pelvic tilt, whereas the function of psoas major is lumbar spine flexion in open kinematic chain. This is very important. So the reason why Illiacus acts on the pelvis and psoas major acts on the lumbar spine is because of their attachment. Your Illiacus attaches to the iliac fossa, whereas the psoas major attaches to the vertebral bodies and also the discs, right? So let us see where their attachment is. So if you take Joe, this is his pelvis, right? So the Illiacus comes from his pelvis and attaches to the femur. That's why the action of Illiacus is anterior pelvic tilt. And then if you look at the psoas major muscle, it comes from the vertebra. There is vertebra over here, right? So from the vertebral body it comes, and then again it comes, forms a common tendon and then attaches at the femur. So both cause hip flexion, but through lumbar spine and then through the pelvis, that is the iliac crest attachment. So that was the movement in the open chain. What about a closed chain movement? In closed chain, his trunk will be fixed and his lower body will also be fixed, right? So pelvic tilt or hip flexion will be definitely occurring. So in closed chain, anterior pelvic tilt will be occurring, and also there will be compensation that we have talked about in our previous videos. Do check out my video on pelvifemoral rhythm, where I have talked about this. There will be lumbar lordosis that will be seen as a compensation because it's in a closed kinematic chain. Another very important point is the hip flexion past 90 degree is done only by these muscles. Okay, so these muscles do hip flexion past 90 degree. Why? Because other muscles that are present at the hip joint, like your rectus femoris or sartorius, they are two joint muscles. So here the active insufficiency will come in play. Because these are two joint muscles, they will be already contracted at the other joints. Hence, they won't be able to produce that much force beyond 90 degree of hip flexion. Hence, hip flexion past 90 degree is majorly done by your iliopsoas muscle, that is Illiacus and psoas major. So now that we have covered iliopsoas muscle, let's move on to the next one, that is your rectus femoris. Rectus femoris starts from your AIIS, that is anterior inferior iliac spine, which is slightly inferior to the ASIS, that is anterior superior iliac spine, and it then goes and attaches to the common quadriceps tendon. So if you take Joe, it starts somewhere from here, that is your anterior inferior iliac spine, and then goes and attaches to the common tendon of the quadriceps. It is a very superficial muscle, and it is very commonly injured in footballers. Okay, so this is the most common quadriceps strain that we talk about. Another two properties that you can mention under rectus femoris is active and passive insufficiency. Now whenever there is a two joint muscle, you have to talk about its active and passive insufficiency. If you already know about it, you can skip this part because I'm going to explain now what active and passive insufficiency is. Basically, active insufficiency is inability of the muscle to generate force at both the joints when it is in a contracted state. So if I contract my rectus femoris, there will be hip flexion and also knee extension. And when both of these occur, the rectus femoris cannot generate enough force. Okay. So that is your active insufficiency. And what is passive insufficiency? When I'm trying to stretch the rectus femoris, it's exactly the opposite. It's inability of the muscle to stretch at both the joints, okay, simultaneously. So when I'm stretching the rectus femoris at hip joint, that is hip extension, and then knee flexion, it's getting stretched at both the joints, right? So it is not able to stretch efficiently. That is your passive insufficiency. So these are the 2 points again you can mention under rectus femoris. So coming to the next muscle, the sartorius, it is a very thin muscle. So if you see over here, I mentioned it's a very small muscle and we are not sure if it plays a major role, okay? Especially it has function of stepping up. What is stepping up? So when you are going up the stairs, you will be doing hip flexion over here, and also knee flexion, right? So this specific function can be done by sartorius because of its attachment. Where is it attached? It is attached from your ASIS. So ASIS is over here. So it's on the lateral side of the hip. It starts from the lateral side of the hip and then comes medially and attaches to the medial condyle of the tibia. Okay. So it attaches on the medial aspect of the tibia and starts from the lateral ASIS of the hip. Okay. So this is how your sartorius is attached. What does it do? It does hip flexion. Obviously we are talking about flexors and it is on the anterior side, and as we know, whichever side the muscle is placed, that is the direction in which it will cause the movement. So it is on the anterior side, so it will cause hip flexion. It will also cause hip adduction and lateral rotation. At the same time, it will cause knee flexion because it goes slightly on the posterior side as it attaches, okay, knee flexion, and also it is on the medial side, so it will cause medial rotation at the knee joint. So next muscle is the tensor fascia lata. So the tensor fascia lata is in close relation with your IT band. So if you understand the attachment of the IT band, you can easily understand how the tensor fascia lata works. Okay. So the IT band is attached at the two ends, one at the lateral part of the tibial condyle. So if you take Joe, it's over here at the lateral aspect of the tibial condyle, and then the IT band goes and then it attaches to the iliac crest through your TFL, that is the tensor fascia lata, and also gluteus maximus. The tensor fascia lata goes from the ASIS and then goes and attaches to the IT band. So that is the placement of your tensor fascia lata, from the ASIS to your IT band. It does flexion, abduction and medial rotation. Because it's on the lateral side, it does abduction, and medial rotation is kind of a tricky part over here that you need to remember, and also flexion because we're talking about flexors over here, right? Then it also maintains tension in the IT band. Since IT band is on the lateral side, which gives stability to the hip on the lateral side and also your knee. So this tension in the IT band is maintained by your tensor fascia lata. Okay. It also contributes to hip stability, which I just mentioned, and tightness can limit adduction. So if you see, if there is a structure on the lateral side like this, like an IT band, which gives stability to hip joint, which is pretty stiff, and if you try to adduct your leg, what will happen? This IT band will prevent excess adduction, right? But when IT band becomes too tight, it will limit a lot of adduction, and this tightness or stiffness at the IT band can be found out through obers test. So what do you do in obers test? You position your hip in such a way that it will put the IT band posterior to your greater trochanter. So IT band will be somewhere over here, right, like this, and your greater trochanter is the most prominent part that you can feel on the lateral aspect of your hip. So IT band will be put in more posterior part of your greater trochanter, and then you'll drop your hip, and as you drop your hip, if it easily drops, that means your IT band is totally fine. But if it's very tight, it won't let your hip drop at all. So that is how you know that IT band is tight. Again, I would like to discuss about more practical approaches in the future videos, but for theory, this is all. So next, going to the snapping hip syndrome, which is commonly seen as a pathology of tensor fascia lata or IT band, both kind of interrelated. So here what happens is there is inflammation of the greater trochanteric bursa. So the greater trochanter I talked about over here. So there is bursa between the greater trochanter and the muscles over here and the IT band and TFL. So when there is inflammation over here, when you are walking, every time you are walking, there is snapping that is occurring or popping sound that you can hear at the step, at every step you take. Okay, so that is the hip snapping syndrome that is commonly seen in tensor fascia lata and IT band related pathologies. So going ahead with the last part, there are some secondary hip flexors like pectineus, adductor magnus, and also adductor longus and gracilis. These are predominantly adductors, as we saw in our previous videos. They are more of adductors, but as the position of the hip change, they can also cause hip flexion. So that is something you need to keep in mind. So pectineus and gracilis was the PG that we were talking about, and this were the adductors for the adduction. So PG trips on adduction, if you remember. Now going to the next part is the function dependent position, right? So once the femur is in superior to point of origin, so wherever the muscle is originating from, if the femur crosses that point, it will extend. When I mean by extend, these flexors can do function of extension when your femur goes more superior to the point of origin. The gracilis muscle can cause hip flexion with knee extension but not with knee flexion. So if I take gracilis, which was over here like this on the adductor side, what they'll do is they'll cause hip flexion with your knee in extension position. That's fine. But if your knee is in flexion position, they are not causing hip flexion. Okay, so now let's summarize the topic. We talked about the iliopsoas muscle, which consists of iliacus and psoas major. They mostly do hip flexion past 90 degree because of other muscles active insufficiency, because these are not two joint muscles, right? Then we talked about rectus femoris. Rectus femoris, we talked about its attachment, active and passive insufficiency, and how it gets commonly injured. Under sartorius, we saw its attachment. What is its function at hip and knee? That is, at hip it causes flexion, adduction, lateral rotation, whereas at knee it causes flexion and medial rotation. Then we saw how it helps in stepping. So sartorius helps in stepping, SS, something you can remember. Then we took our attention towards tensor fascia lata, how it is closely related to IT band and it provides stability to hip joint, as well as when it gets tight along with IT band, it can prevent adduction. Then we also talked about the snapping hip syndrome, and then we looked at some secondary hip flexors which have function of adductors mostly, but as the position of the hip changes, their function can also change. So with that, we finish up the flexor topic. Just wanted to get you guys back to the main classification. So over here we have covered the trips muscle and the adductor muscle, right? So some of the adductor muscles. Next video will be focusing on the adductors specially. So that's all for today, guys. Thank you for watching. If you like my content, please share it with your friends. Don't forget to hit that subscribe button and please like the video, as it really helps me out. And also let me know in the comment section what other videos you would like me to cover. And see you soon in the next video.